Hello? Hello? All right, we're going to get started here. So it came to my attention that one of the groups that was a potential victim for today has some like skit or something prepared from another group. So I was thinking if it's okay with Dr. White, maybe they can incorporate their skit into our presentation here. And it's okay with Dr. White, so. One of the groups. Nobody? I thought there was like a skit prepared or something. All right. So, how do we turn this on? Display? No. Sorry. Okay, so we're group 32, and we'll be presenting case 1, and we're fully prepared to embarrass ourselves fully here for your entertainment. So let's get started here. So we're going to speak with an accent here, and it's going to be chosen random using Dr. Barnes's algorithm here, so let's see what we end up with. All right. This is the accent hat. Dr. Sarma, thank you. All right then, let's get started here. So there we were in clinic. A 76-year-old man with a history of hypertension and diabetes came in complaining of progressive dyspnea during minimal activities of daily living. Danger. This man is in some serious danger. On physical exam, his jugular venous distension was increased. He had peripheral edema and a third heart sound. His BNP levels were elevated at 1,000, and on chest x-ray, we found cardiomegaly and pulmonary congestion. This man's got one foot in the grave and the other on a banana peel. Serious danger. You're on it.
I don't know how I can follow that. I'll wear the hat. All right, I'm just going to take a second and look at the EKG here. We've basically got no... Is my hat falling off? All right, so we have a normal sinus rhythm, and our axis is about -30. We have signs of left ventricular hypertrophy in our lateral leads. We see in V5 and V6. We've got some pretty big Q waves with some ST changes there, also indicative of left ventricular hypertrophy. We're not really able to measure, but it looks like the QRS could be getting a little bit wider as well. So that's what we're looking at. Next up is Dave Joyce. Do you want the hat?
Of course. Oi. My spiky hair. Hello. I'm not sure if my Australian accent is truly Australian, but I'm just going to roll with it. And thank you, Chris. I appreciate it. Physical exam findings, we see... Right. Physical exam findings, we see elevated jugular venous distension. We also know that as venous hypertension. It's a common finding in heart failure. Also peripheral edema due to increased hydrostatic pressures. This occurs when filtration is greater than reabsorption. The S3 heart sound, also known as a gallop, sounds like Kentucky. I would go ahead and do that for you, but I'm pretty sure that Dr. Karula handled that last year. occurs at the beginning of diastole, and it's due to volume overload, which is, in the case of rapid ventricular filling. And if the S3 sound is best heard at both the tricuspid and mitral locations on the chest wall, it indicates congestive heart failure. Last, we have the chest X-ray, which shows the enlarged heart, or cardiomegaly, and pulmonary congestion. Next up is David Kay. Josh, David Kay.